It takes about 3 seconds and a thumb tap to get a hot meal delivered right to your door. But if you live outside a major city and need to see a doctor, the journey looks a lot more like this. Tech platforms like Zomato and UPI solved their massive logistical problems by separating the actual service from the physical infrastructure. UPI is India's instant, real-time digital payment system that facilitates interbank peer-to-peer transactions. While these platforms have digitized our economy, healthcare is still stuck in the physical world, completely bottlenecked by geography. For millions of rural patients, getting a basic diagnostic blood test or consulting a specialist means a grueling 30 to 50-kilometer journey and a wait time of up to 4 weeks. We are left with a glaring paradox. The digital revolution has seamlessly connected our consumer economy, yet it has almost entirely bypassed the most critical sector of human survival, leaving a massive, lucrative vacuum in the market. The government's attempt to fill this gap relies on primary health centers, or PHCs. PHCs are state-funded rural clinics that serve as the first point of contact for patients in the public health system. But these facilities suffer from severe infrastructure gaps and a massive 25% absenteeism rate among doctors. This chart shows the average monthly medical expenses across income groups in rural India. Notice how high the dark blue bars remain. Even with free government medicine, the hidden economic costs of travel and lost wages create a massive financial drain. We've seen this exact behavioral shift before in education. Rural families previously abandoned free, state-run Zilla Parishad schools and paid out of pocket for private English medium schools, simply to secure reliable quality for their children. That exact migration is now happening in healthcare. Rural patients are actively choosing to bypass free government care, preferring to pay out of pocket for private alternatives because they value timeliness and reliability over a broken system. The demand for private, high-quality care is absolutely massive, but trying to meet that demand by building traditional brick-and-mortar hospitals across the countryside is too slow and way too capital-intensive. This is a logistical problem that requires a radically different business model. The Indian government has already quietly built the digital infrastructure needed to solve this. It's called the Ayushman Bharat Digital Mission, or ABDM. ABDM is a national framework designed to integrate digital health infrastructure and bridge the gap between different healthcare stakeholders. The core of this system is the Ayushman Bharat Health Account, or ABA. ABA is a 14-digit identifier, functioning exactly like a digital payment ID, securely linking your entire longitudinal medical history instead of your bank accounts. Instead of records being trapped in hospitals, ABA creates a decentralized digital locker. Your history becomes portable. This is powered by the Unified Health Interface, or UHI, an open network allowing patients to discover, book, and pay for services across any provider without app lock-in. Crucially, the system uses a consent manager framework. Patients maintain strict, granular control over their data, granting explicit, time-bound permission whenever a doctor or lab needs to access their records. The digital tracks for a massive, frictionless healthcare network have been laid, perfectly mirroring the infrastructure that revolutionized digital finance. Now, the system is just waiting for an orchestrator to utilize it. Enter the orchestrator model. Instead of taking on the massive capital expense of building physical hospitals, a central platform aggregates thousands of fragmented, independent providers under one digital roof. To scale physically, the platform uses a hybrid gig and franchise expansion strategy. They deploy independent local entrepreneurs to operate standardized physical access points right in their own villages. It's essentially a business in a box. Local workers, known as community health entrepreneurs, are equipped with automated screening kiosks called health ATMs, AI-powered diagnostic tools, and trusted platform branding. Community health entrepreneurs are rural individuals trained to provide basic preventative care and collect health data in their communities. The financial engine driving this rapid physical expansion relies on strategic partnerships with non-banking financial companies, or NBFCs. NBFCs are financial institutions that offer lending and credit services without holding a traditional banking license. These lenders provide zero-collateral equipment financing to these otherwise unbankable rural partners, so they can launch their clinics immediately. While the franchisees handle primary care, the parent entity manages specialized asset-light subsidiaries to fill the complex gaps. This includes deploying mobile fem-care vans to ensure privacy for female patients, and setting up smart ICU hubs that allow city specialists to monitor rural patients remotely. By decentralizing the physical hardware and financing independent local operators, this platform model allows high-quality healthcare to scale across the country at the rapid speed of a software deployment, bypassing the grinding pace of construction. Let's look at what this patient experience actually feels like on the ground. Instead of traveling 50 kilometers and losing a day's wages to reach an understaffed public hospital, a rural patient simply walks down the street to a local franchised health ATM owned by a neighborhood gig worker. The transaction is completely transparent. The patient pays a low, flat fee, say 350 rupees, for a hospital-grade, AI-backed physical screening. There are no hidden fees, completely eliminating the fear of medical sticker shock. The data flow is immediate. The screening results are instantly pushed through the open UHI network directly to the patient's ABHA account, where a specialist sitting in a city hundreds of miles away reviews the file in real time. The combination of local franchise logistics and open digital rails successfully compresses a multi-day, highly expensive, and exhausting ordeal into a simple 10-minute, affordable transaction right in the patient's village. Zooming out, the platform acts as a massive orchestration layer, seamlessly connecting rural patients, independent local pharmacies, drone logistics networks, and remote city doctors. The companies that define the next decade of healthcare will not be the ones pouring concrete to build the most hospitals. They will be the ones building the invisible digital rails that connect the entire system together.